So it's getting live, and we'll just wait for a few seconds and then we can just begin. Just wait for a few attendees to join. So attendees have joined. Dr. Ashish, over to you.
Yeah, thank you, Bhupesh. Good evening, everyone. Good morning. I welcome you all for this grand round. And I would like to introduce myself. First of all, I am Dr. Ashish Manocha. I'm here in the capacity of Head of Department of JSPH at Pune University, Jaipur. And I would like to introduce Dr. Anil Purohit. And he is here in the capacity of CEO and founder president of JSPH. He resides in Boston, and he serves as the director of Stem Cell Foundation for the Harvard Medical School. So I welcome you all again. Over to you, Anil sir.
Thank you, Ashish. Good evening, everybody. Good morning, people joining from United States, or good afternoon to people from Europe. It's a pleasure to be here on this platform, and we have one of the very good distinguished speakers today. He's very well trained in India and the United States, and we'll be hearing his perspective today as an immunologist, what he has to say about COVID. And one of the most popular physicians who has been working in the front lines, I could say, on this particular pandemic. And Priyakant will give a great introduction about him. I am honored to have my colleagues from Purnima University, Dr. Manoj Gupta, Dr. Sudhir Rajiv, my colleagues, my friends, Rahul Singhi. He is not able to join today. He is, I would say, biking or driving from Jodhpur to Jaipur, and Jagdish just left Purnima University and he's driving to Delhi, so they may not be joining. But we're just so glad that you all are here, and we have good attendance today. And Dr. Sitesh Roy also runs a fantastic channel, actually, his own channel, and I think people will be viewing, and it'll be great to hear him. And he has been on our webinars before, and I've referred a lot of patients to him, and the feedback is amazing. So it'll be great to hear from him. So without taking much time, I will give it to my colleague, my friend, I don't know what else I can say, Priyakant. Known him for more than a decade now. We were together in Chennai at the University of Washington's ITech program. Currently, he is based in Turkey as a WHO officer. He'll tell you more details what exactly he does. Of course, working on COVID. He did MPH at Jodhpur School of Public Health. By training, he is a physician and has worked for Centers for Disease Control of the United States at the US Embassy in Delhi. And I could, talk more about him, but maybe some other time. But Priyakant, over to you.
Thank you, Dr. Anil, and good evening and good morning to all across the world attending this, threat in emergence variant in COVID response. So I'm not talking about myself because already Dr. Anil has told. So I work as a WHO officer leading the health security project for regional office for Europe and based in Turkey. And coming to the variants, it took, if you see the evolutionary changes of the COVID-19 virus, it took a year now for Omicron, the 5th variant of concern, to be detected after Gamma and Delta. So you never know, in next year, same time, we'll be talking about another variant, or sooner, we might be following sort of words to name those variants. So without wasting much time, I would straight away give a brief introduction about Dr. Sitesh Roy. He is a super specialist in allergy, asthma, and clinical immunology. He is the founder of Dr. Roy Health Solution Multispecialty Clinic in Bandra. And he's also been the formal medical director of the Dr. Nibdakar Asthma and Allergy Health Clinics. So he has an extensive experience working in this area and has a lot of publications, if I could name it, in leading medical journals, as well as a book. He actually wrote, chaptered in stress and allergic disease. And he's also been listed as the best doctors in America from 2005, 6, 7, 8, 9, 10, and again in 11, 12. So glad to have you, Dr. Sitesh, in this panel. And also, he is one of the, is in the Guide to American Staff Physicians. So it's a privilege to have you in this seminar. Over to you, Dr. Sitesh, and without wasting much of time, we'll straight away start this, webinar. Thank you.
Thank you very much, Dr. Priyakant, and thank you to Dr. Anil, Dr. Ashish, and the entire JSPH team for having me over once again in your grand rounds. A very warm welcome to all our delegates joining from all around the world. Truly, this is a wonderful platform that we have with JSPH, and it's my pleasure to speak about a topic that we have all been dealing with and facing throughout this past year and a half or more now. Just trying to get my screen to show up.
Perfect, Dr. Sitesh.
Are you all able to see the entire screen?
Yes, it
Perfect.
is.
Go ahead.
Problem is, I am not able to see it completely. My computer has done something where it has kind of narrowed the display where the edge is getting cut for me.
Dr. Sitesh, I'll request you just to stop the sharing once and then reconnect. Kindly stop sharing and then share again.
Okay, I'll do that. It's doing the same thing again. Just a second. Okay, here we go.
Okay.
So we are speaking on the threat of emergent variants in COVID-19. We're going to think about or talk from the clinical immunology standpoint, which is my area in strength and forte as an allergist immunologist. We are talking about coronavirus, which we have known since at least the 1960s through what is called the common cold viruses. And I will come back to this 229E because this virus has a lot to teach us about what coronavirus in our SARS-CoV-2 could be doing. There are obviously 7 human coronaviruses. 4 are what we call normal coronaviruses because we've known them since 50 plus years. And 3 are novel, which was the SARS-CoV, the MERS-CoV, and now the SARS-CoV-2. This beta coronavirus family to which SARS-CoV-2 belongs, compared to SARS, which had taken the world by a storm in 2002-3, is a much bigger virus with a lot more diversity, a lot more room to do stuff that we have never seen coronaviruses do before. And we've obviously gone through a variety of variants, alpha, beta, gamma, delta, and now we are at Omicron. Now with Omicron, there's a lot to speak about given its significant mutations, and we'll come to that a little bit later, but some unique features of having very significant infectiousness, contagiousness, and also causing disease in the asymptomatic phase is something that SARS and MERS had never done before. So clearly this virus came in with some huge advantages to what it's capable of doing with the human body. Another very important thing to understand is the angiotensin converting enzyme 2 receptors that this virus enters the human body through, though we know they are largely concentrated in the upper and lower airways, they're present in pretty much every tissue in the human body, which is why this virus not just causes a myriad of symptoms, but it also causes something called the long COVID syndrome, because its effect on the nervous system, whether it's the sympathetic, parasympathetic, or the normal nervous system, is immense through variety of receptors. We also will have to understand that as the viruses mutate and new variants emerge, they tend to have some different type of tropism, some different type of binding in different parts of the body, because of which their presentation of symptoms have been quite different. We are all aware of the structure of the coronavirus, and it's just good to once see it, because the spike protein is where the whole world has been concentrated, because that's where all the vaccines work and all the mutations that we talk about and the ways to identify them through the variety of RT-PCRs and rapid antigen tests are focused on. But there's also something called an envelope protein, a nucleocapsid protein, a membrane glycoprotein, and then the ultimate RNA or the nucleoprotein of the virus, all of which we need to recognize, because some areas of this virus are immutable. They do not change. And there are some that can change and adapt significantly as the virus grows and evolves in its journey through the human range, as I would call it, throughout the world. Now, recognizing each of these, we know that there are different structural proteins that are encoded by the coronavirus genome. And being an RNA virus and a negative sense RNA, a positive sense RNA virus, this virus has the capacity to create errors when it is replicating. And these errors can either be at its disadvantage or advantage. And depending on that, when there are a significant number of advantageous mutations that have occurred, we then have a new variant that we talk about. Just coming to these common cold viruses, the 229E, NL63, OC43, and the HKU1, these have predominantly receptors in the upper airway. They are unique receptors. The seasonality is unpredictable. They tend to be present throughout the year in certain parts of the world. In other areas, they tend to be only in winter, and they mostly cause cold, cough, runny nose, a croupy, dry cough, rarely pneumonia of NL63, and then a mild diarrhea sometimes in infants. But we have to remember that there are a lot of other upper respiratory tract viruses, something called the rhinovirus, also known as the human common cold virus, influenza A and B, adenovirus, parainfluenza, RSV, respiratory syncytial virus, and the human metapneumovirus. Why are these important? Because as we get into the winter months, these viruses are going to have their own mechanisms and circulations that are going to go on as per their routine. And on top of that, we now have a virus in Omicron, which is capable of giving largely upper respiratory symptoms, but also some lower respiratory symptoms. And we shall discuss about that in just a little bit. We know about the origin, bats to mammals, mammals to humans. Without getting too much into the controversies that surround this whole area, the important thing now for us to realize is this virus can re-enter animal hosts like pangolins, white-tailed deers, and others, and come back to humans with even further mutations, which can make them deadlier and more scary. And it has clearly been shown that right from lions to cats and dogs and many other animals can temporarily be hosts to SARS-CoV-2, though the good news has been that they don't tend to replicate, multiply, and spread from animals to humans in these, what we would call technically pet animals, though a lion is not really a pet. But the point being that in certain animals, it can have a much more rampant spread within the colony and then come back to humans if they are come in contact or are eaten or whatever else it might be that can happen to them. The transmission we know through respiratory droplets, hand-to-mouth transmission, viability on various surfaces, though we know surface transmission is not the key. It's really the airborne transmission, which can be up to 60 feet in closed spaces, studies have shown. And that's what leads to super spreader events, as the most recent Omicron super spreader event in Norway, which led to almost 100 people getting infected within a couple of hours, suggesting the rate and speed at which this virus can spread in closed, not well ventilated spaces. We also know that it has GI shedding. Everything that we do in a pandemic before the pandemic occurs seems alarmist, and everything we do after will seem inadequate. And that has been the story throughout the last 1.5 years. We know that there are outbreaks, then there is endemic disease, then there are public health emergency concerns, then there are epidemics, and ultimately the pandemic which we are dealing with. And what we have to realize is one of the endpoints of this pandemic might become endemic, where the disease then has small pockets in which it rises, which it seemed to be doing as the Delta variant swept across around 200 countries around the world, and then cases really reduced till Omicron came along and reminded us that this is still a pandemic and it's not becoming endemic anytime soon. The R0 number, which we have all heard about, which is the number of people who can be infected from a single individual, we know that this R0 for Delta was 1, which means one person infects one more. This was higher than what it was for Alpha variant, which was more like 0.7 at baseline, if you think of it as a transmission rate. But when it comes to Omicron, we are looking at least 3.47, and the doubling rate of Omicron is estimated to be 3 days as far as we have early data, recognizing that this virus was only first documented on November 11th, just about a month ago, and it was officially reported only around November 24th with all its sequences. We've been speaking about the variants, and we know that the Greek alphabets are where they come from. We are already at Omicron. We can see that there are about 8 more letters to go. We have already gone through some of the variants like epsilon, zeta, eta, theta, iota, kappa, lambda, mu, without really hearing too much about them. But when it comes to the most recent one, we have again heard a lot, and we'll know why in just a bit. The timeline of these variants, we had the alpha variant September 2020 from UK, the beta variant in May 2020 from South Africa, the gamma variant November 2020 from Brazil, the delta variant October 2020 from India. So remember, there were descriptions of this variant from other parts of the world also in October and November of that year, though it became a major issue in India only in the months of March and April of 2021. Omicron, on the other hand, from the time it has been detected to its spread has been record, means literally we are talking about days, if not even weeks, in which it has crossed 63 countries around the world and has really taken things by a storm. When we look at the daily confirmed COVID-19 cases as of day before yesterday, December 12th, we can still see that India and Japan are at the bottom, but we have still pretty high cases in the US, Germany, UK. And we obviously know that when we look at places like South Africa and UK, the daily new confirmed cases are at a pretty high positivity, where mostly numbers in the orange or the red are very, very significant. India, luckily at this point of time, is still slow, but we also have to remember that the amount of testing that is being done in India had slowly tapered off over time. And so when we look at these rates, it is all dependent on how many tests are being done. We also have to recognize that people got complacent with this virus, people were not going to get investigated as fast as they should, and they were during the peak of the pandemic. So I think some degree of complacency and kind of pandemic fatigue has set in different parts of the world. The case positivity rates, again, very similar trends that we saw in the previous slide. The rate of Omicron as a variant in the COVID scene, as we can see, the numbers in South Africa have really very significantly between 1st November and 10th December increased very, very dramatically. We can see that Germany, Norway, UK are showing a rise, as we would expect, as the cases spread and the number of reports increase and the genomic analysis and testing increases. Omicron clearly has a much faster rate of spread, as I mentioned. You can see from day 0 to hardly day 10, the rise from hardly a few cases to almost 8,000 cases is really a record speed. And I think that the biggest advantage that this variant has gained has been on its infectiousness and transmissibility, contagiousness, whatever you may call it, and its ability to infect people very rapidly through its changes in its structure, as we shall see. When we look at the SARS-CoV-2 sequences by variants on December 10th, 2021, South Africa 100% had become Omicron. Botswana 23%, Spain 11%, France 6.7%. As we can see, though in UK it's only 1%, it is the fastest growing variant there also, suggesting that clearly between Delta and Omicron, where Omicron really did not originate from Delta. The thought was that Delta would mutate, and we have 4 versions of Delta. And as you all know, the AY4 variant is what has now caused a resurgence of cases in China. So AY4 variant of Delta is causing a increase in cases in the eastern provinces of China, while we have Omicron now rising its head seriously up in South Africa and other parts of the world. So we can see that now these different variants can run in parallel. And one of the concerns that we have, both microbiologists, virologists, immunologists have, is what if these viruses co-infect a person and then come up with a stronger and more resilient version that is the better of both worlds. As we will see, Omicron is not a derivative or a lineage derivative of Delta virus. It's come just out of nowhere, literally. Why are these different, and why is Omicron not raising a major red flag yet, though we are concerned about its speed of spread? Because it tends to have a milder disease than the Delta variant. So in the Delta variant, loss of taste and smell were very, very prominent, very high fevers, cold, and then cough, shortness of breath, significant oxygen requirement, very, very significant, so much so that parts of the world went through major shortages of oxygen, and then the gut symptoms. When we look at Omicron, we realize that it's a milder disease. It causes headache, extreme fatigue, and tiredness. A very unique symptom that is being described in South Africa is excessive night sweats, to the point where a person wakes up from their sleep with their sheets drenched, something that we have not seen with the other COVID variants so far. And then body aches, a very scratchy throat, though simple scratchy throat has been present even with the previous variants, but a very scratchy throat is also being described as something that had not been seen before, though we have had patients with other variants through the pandemic that we have treated who have had itchy, scratchy throat as one of their primary symptoms when they present. A dry cough and a fever that's not very high. Remember, one of the biggest differences we saw with Delta was fever that lasted 10, 12 days, and again going to 102, 103, with significant risks associated with worsening and the disease progressing during that time, all the way to COVID pneumonia and multi-organ failure. Luckily, we are seeing that Omicron is not doing that. There's less COVID pneumonia, there's less oxygen requirement, there are less hospitalization and ICU admits, but it does seem to be affecting 20 to 40-year-olds the most. So the young, active, studying, working populations around the world getting affected is a real concern, because even if someone is out of action for just 4 or 5 days, it does put a significant burden on the system. And remember, when a large number of people get sick together, it puts a major burden on the healthcare system also. Compared to where the Delta wave was, we can see the share of ICU beds and ventilator patients is much less with the Omicron wave, as seen in Gauteng, which is one of the main provinces where this virus has been most closely studied, and one was the earliest areas to report and get tracking on this Omicron variant. So we are dealing with a milder virus, but a much more rapidly spreading, 3-4 times faster, causing milder disease. But as more and more people get it, we do not know if it starts affecting the elderly as it makes its way around the world to other parts of the areas, goes into nursing homes. We do not know what even this variant might do at this point of time. Coming to our immune response to COVID-19 by infection and vaccination, we have to realize that when we look at SARS-CoV-2, there are clearly immune memory cells that are produced simultaneously with the antibodies. Now, the entire focus of the entire world has been on spike protein antibodies, IgG, and the neutralizing antibodies. And we do realize that these can persist, but they can decline over time. We have heard it with vaccination that the drop is more significant between 6 and 9 months. But we know that that is not the case for everyone. What we have to realize is look at the left side where we talk about the immune memory cells. And these memory cells, which are the spike protein antibody producing B cells. So there are B memory cells and then there are T memory cells, both of the helper kind and the cytotoxic kind. And we realize that these persist for much longer. What does this mean to a human being? It clearly means that if they are exposed to a virus in which these things can be recognized, because these are formed not only to the spike, but also to the membrane, envelope, nucleocapsid proteins, and these have a much longer lasting effect. In fact, in the SARS-CoV, when we look at the previous pandemic from the SARS-CoV family, those antibodies, or rather immune memory cells, have been shown to persist for even 4, 6, and 10 years past infection. And that is one thing that we are not testing or checking. We are only checking antibody titers and we are trying to correlate it with reinfection or disease. And I think that's where we might be in some ways jumping the gun, but we also have to be careful because this is a disease that has not shown us every bit of what it can do. When we look at the antibody titers over time, we do realize that even the other coronaviruses, once a person is exposed and infected, persists and continues to have antibodies. But these older coronaviruses, what was called the normal coronaviruses, which have been around us since the 1960s, what do they do after a couple of years of causing a person's infection when their immune system kind of tapers down? But more importantly, the virus mutates and changes itself. And that is exactly what we saw with the 229E variant, which has been very carefully studied from the 1980s to the year 2021. And it was found that the antibodies produced in the 80s worked well for the virus in 1984. The antibodies produced later on worked well for the later variants. So clearly, coronavirus, even in circulation in our communities for the last 50 years, has been going through this phase where after a certain time, when the immunity wanes, it can cause a new infection, but generally not as severe as the very first or original one. And remember, that's how newborns and babies who have never seen any virus or bacteria in their whole life develop their immunity. And that's how kids get the RSV virus in the first year of life, but later on, if they get it as adults, it's a common cold and not a bronchitis, bronchiolitis, or a pneumonia, as RSV can cause and put a child into an ICU even. So we have to realize that as more and more people are exposed either through infection or vaccination, the number of cases that we will see will eventually, in terms of severity, intensity, go down. But we'll talk about more about it in a little later part of the talk. As we see in the mutations, Delta had about 19 mutations, 10 in the spike protein. Omicron has 50 mutations, 32 in the spike protein, and certainly getting a clear advantage for rapid transmission, though there may be differences in the level of depth of penetration of this virus into the lower respiratory tract. And hence, as a result, it tends to cause other systemic symptoms rather than causing the classic oxygen-dependent pneumonias. Why are these mutations important? Because one of the prime modalities of treatment around the world these days for mild COVID, so that it does not become moderate or severe, is to use these antibody cocktails. There is something called imdevimab and there is something called casirivimab. And both of these antibodies bind to the spike proteins and essentially help the body identify and remove them from the circulation through the help of the rest of the immune system, including the macrophages, the natural killer cells, and all the other cells. So a very smart way of designing this. But what did the virus do? The virus, purely because of its opportunity to infect millions of people, came up with changes where these antibodies are not binding as well. And it has already been shown in vitro studies that monoclonal antibodies are failing against Omicron. The amdevimab and the casirivimab, 2 antibodies in the Regeneron drug. There are others also which are being studied, but these are failing to neutralize Omicron, but they efficiently prevented Delta infection. The conundrum that this presents to treating physicians is you can't really do a genomic analysis for every patient to test positive. Now, there are some advantages that on the test, if you have a S gene failure that is seen in the test, you can indirectly know this might be Omicron and not Delta. But when it comes to treating patients, we might be using a lot of monoclonal antibodies for the milder cases of Omicron, where it is completely useless, putting a huge burden and cost on the system, and raising the very important point that we will have to keep up with a changing virus, with changing medications and vaccines as the virus mutates and grows and goes ahead. When we talk of vaccines and its effectiveness against the new variants, we have to consider whether antibodies triggered by the current vaccines can recognize and neutralize the variants, whether there are cross-reactive cellular responses to these variants, and most importantly, the real-world impact of the variants on the clinical protection provided by the vaccines. The vaccine efficacy with the previous strains, we know that with certain vaccines where it was at 90%, it dropped down to 80, further went down to 70. So we can see that, in the alpha variant for the different vaccines, the delta variant for the different vaccines, the beta or gamma variant, there were slight decreases that were seen in the efficacy. When we look at the risk of severe disease, this decline was not seen with the vaccine with the previous strains, and that was the biggest relief that we had. However, with whatever data we have so far from Omicron, we are finding through these studies that the efficacy of the previous vaccines, which are, remember, largely based on the original Wuhan variant or the alpha variant, and all the structural changes that were there in it, primarily on the Wuhan or the original variant, we recognize that the efficacy of the vaccines can drop down to as low as 30 or 40%. And especially if the person has had the vaccine more than 6 to 8 months ago, then that efficacy in the most recent studies, which we are finding done mostly in vitro or for people who are having a reinfection, is significantly dropping down. I don't have slides on these because these have not reached publication yet, but we clearly know that if the person has had a vaccine more than 6 to 8 months ago, with their ability to still fight off the Omicron variant drops down to below 50%. Now, if they get a booster vaccine, which is being pushed by, especially for the mRNA vaccines, it has been shown that you can potentially increase that ability to about 75% the vaccine efficacy or effectiveness. So there is some data to suggest that, but how much that will work, for example, with Covaxin, or how much that will work with the AstraZeneca Oxford vaccine, or how much that will work with the J&J vaccine, we still do not know. This data is still not available to us, which will bring us to another conundrum that we shall discuss. There's a Frankfurt-based team at Goethe University in Germany, which has found that compared to Delta variant, the blood serum from double vaccinated, Pfizer vaccinated individuals had a 11-fold reduction in efficacy after 6 months against the Omicron variant. Even amongst those who had received 3 doses of the vaccine, there was a 24.5-fold reduction in efficacy against Omicron compared to Delta. The blood serum from people double vaccinated with the Moderna vaccine showed a 20-fold reduction in efficacy. And for those who got the Pfizer-BioNTech booster dose, after 2 doses of Moderna, the fall was 22.7-fold in neutralizing the Omicron variant. This is concerning because clearly it means that our old vaccines or our existing vaccines are not able to do a very good job with what currently still seems to be a milder variant in terms of disease severity. But we can only be concerned that if this happens with ongoing mutations and new emerging mutations, are we keeping up our vaccine development with these mutations, and what will it mean for the future? When we look at the share of vaccinated people against COVID-19 as of December 12th, 2021, if we look at India, we realize that about 37% have received both doses and another 22% have received one dose. So we are nowhere close to herd immunity. But when we go lower down and we look at Ethiopia, Nigeria, Tanzania, Kenya, we look at places within Africa where the rate of vaccination is very, very low, though we realize 56% of the world population has received at least one dose and almost 8.5 billion doses have been administered. There are still places where only 7.1% of the people in low-income countries have received at least one dose. And this vaccine inequality, as we call it, is a concern because wherever there are unvaccinated individuals and the virus is still widely spreading, new variants can develop. We know that new variants can develop amongst vaccinated populations also as the virus develops its evasion techniques. So we know that Omicron has the capacity to infect people who've previously had infection or vaccination. And we know that it can certainly evade the immune responses. It can transmit faster, wider, with possibly lower viral loads, which is one of the mechanisms by which it spreads faster. So more efficiently spreading through the mutations that it's developing. But having more uniform vaccination around the globe can certainly help us convert this disease potentially into a milder disease as time goes by. So what does the future hold for us? The SARS-CoV-2 becoming endemic along with the 4 seasonal coronaviruses that have been around since 1960s is a real possibility, but still to me seems like a distant possibility unless, as some theorists say, or some people who develop models say, that something like Omicron goes around the world, infects a lot of people, gives them a mild disease, and then eventually everything that comes after it would be mild. We would be hopeful and optimistic to think that way, because as I said, simultaneously in China, the Delta AY4 variant is causing outbreaks. But again, we are seeing small pockets that we are getting better at controlling. Lessons from repeated cold causing coronavirus 229E that I mentioned. The virus evolved to evade immunity while causing milder disease. That may be kind of what Omicron is doing. The newer variants that escape pre-existing immunity and antibodies are our concern. Less vaccinated populations become prime targets for the virus to evolve. And again, people with immunodeficiency, HIV or other forms of immunodeficiency, where the virus lingers in the body for longer periods of time, also gives the virus a chance to evolve and change and develop new mutations, because a short-lived infection of 5 or 10 days doesn't give the virus a chance to really do much. Could it behave like influenza, which mutates faster? Though there are some people who believe that SARS-CoV-2 is mutating faster than influenza in some ways, and then cause epidemics or pandemics in the future too after being silent for a while. Could it behave like the respiratory syncytial virus, where the behavior of causing largely infections in infants and toddlers and only mild disease in adults will occur? We still don't know. Could it evolve to become more infectious with faster multiplication and more transmissibility? We clearly see no seasonal pattern in this virus, and we know that the possibility of increases in winter and spring in cases as was seen with the flu pandemic of 1918, 1919, where big rises were seen in these phases during change of weather and during the cold season, is certainly something that we will have to observe and keep an eye on. A virus could evolve to keep a host healthy enough to get a mild infection to get transmitted to others and thus keep the infectious chain going. This is hopeful and optimistic thinking. This is not how SARS-CoV-2 has been behaving, though we would like to believe that that could be the harbinger of the ending phases then of a virus, which then does not go back to becoming very severe. But we know that there are many parts of the world where the Delta and the Omicron variant may coexist and continue to cause problems both severe and mild. The next steps in this challenge: test and quarantine, track and contain, isolate and treat, vaccinate and immunize with global vaccine equality, maintain and sustain COVID appropriate behavior, avoid unnecessary travel and closed gatherings, and most importantly, focus on individual immunity and overall health rather than relying only on external measures and drastic measures like shutting down the world, restricting travel, which the virus has shown it can very easily evade by mutating. And it is already known that there have been cases in almost every country where there is no history of travel, no history of exposure to someone who has recently traveled, suggesting that community transmission of Omicron is already going on, suggesting that this virus silently does what it has to. By the time we become aware that it's doing something, it's often too late. Now, just on the point of vaccination from an immunologist standpoint, a very interesting thing, there is something called the COMCOV study where combination COVID vaccines were used, initially giving the AstraZeneca vaccine, followed by a Pfizer vaccine, to which a very significant and good response of the individual was seen. And I think we're going to hear more and more of this in the near future, where a mix and match approach to vaccination is being considered very seriously, because giving the same vaccine that the virus can very easily grow beyond and evade does not help us. And the need for newer vaccines is absolutely something. I had seriously thought that with the Delta variant doing the havoc and spreading as far as it did, there would be a move to get a new vaccine developed, but clearly that has not happened. Maybe Omicron and everything that's happening with it would make us rethink about the vaccination. And combining vaccinations for which we don't have enough data except for the AstraZeneca Pfizer combination. And to know, even in India, the talk is going on of giving, if anyone needs a booster, which is really a questionable approach in a country where still up to 40% of the patient hasn't even received a single dose. But certainly something to consider to protect high-risk individuals, individuals who have immune deficiency, individuals who are undergoing cancer therapy or other problems, ages above 70, 75, people who have other issues, certainly something that can be considered, but globally doing it for everyone who has received 2 doses, at least for our country, does not seem like the smartest move. And whether combining it with other forms of vaccines is going to be a question that needs to be studied, can't just empirically be done, but it makes a lot of sense. And also, when we look at the level of immunity induced by the viruses, what we realize is people who've had an infection followed by immunization have the most durable immune response, because their immune system has responded to the entire virus and all its parts, and not just to the spike protein, which may not be adequate because the virus can change its spike protein. And it turns out that people who've had infection followed by immunization have some of the highest and most long-lasting immunity that has been seen. That does not mean we should wait for people to get infected and then immunize them. But I'm just saying that these are the ways in which our immune system is behaving and giving us signals. So maybe a combination of a killed whole viron vaccine combined with something like a spike protein vaccine may be a much smarter approach, coming as close to what nature does compared to what we have out there. And so when India gets its own things like the new Corbevax vaccine, or we get our own mRNA home developed vaccine, or we get some of the newer vaccines, I seriously believe that this is a prime ground to combine these different technologies and see how our immune system would do in fighting this very smart and what I would call respectable virus, because it has taught us so much about ourselves and our world these days. With it, the hand washing remains a very, very key measure. Social distancing, using personal protection, gear, all this is very important. Working in as much as well-ventilated spaces, avoiding gatherings, traveling only if necessary. All of these are very important. And ultimately, I will close this being my last slide on the immunity boosting. Because remember, there is nothing like fresh air, sunlight, and a healthy diet, and a good night's sleep and good physical activity. Because remember, there have been pandemics since time immemorial where we didn't have drugs, we didn't have antibody cocktails, we didn't have vaccines, and the human race still survived. And as they say, it's survival of the fittest, we hear this, but we don't apply it in our own lives. And I think it's very, very important that we take this to heart and we take it upon ourselves to make ourselves healthy, so that we are not dependent on what the virus does or what is happening in the rest of the system around us, and we stay safe and stay protected and keep our immunity at its best. The right use of techniques like yoga, pranayama, meditation, prayer, a positive mindset, probiotics, there is a lot that can be done where our immune system can be, as I said, brought to a cutting edge stage where even if a virus mutated and came, it would just give us like a common cold and we would get better within a few days. And that really is the hope, because clearly SARS-CoV-2 does not show any signs of wanting to leave our circles and our human circles. And so we will have to adapt with time, besides everything that we've discussed that we can do. So with that, I shall end my talk and open it up for questions. I'm sure there may be a lot of questions that people may have. Some I may have answers for, some I won't, because there's still a lot of data to come. But I would encourage you all to stay tuned. If you all can, as said, get on my YouTube channel, join our groups. I keep updating and posting videos there. So thank you very much. And we can begin a discussion at this point of time.
Thank you so much, Dr. Sitesh, for a very, very comprehensive presentation. To me, it's a very excellent presentation where you have touched, I mean, rightly said, it's a clinical immunologist, eyes, but not really. You have very well coordinated, kind of related this to the public health aspect. So more or less, when we talk about COVID-19 at this situation, and of course, with emerging strains are being coming up, this is very important to discuss where we are going and what are the challenges that we are going to face, especially with the constraint of vaccines, especially when the cases are being rising across the world, and also in India. For strange reason, we have contained the virus with respect to Delta, but we never know how Omicron is going to emerge. Of course, we don't see death, but we also reported death today in UK. So there is a single hospitalization and death case being reported. So we never know in the times to come how this is, going to be a sort of again as deadliest as Delta. That's just the question of time. But again, I would re-emphasize what you talk about the Omicron's doubling time as compared to all those variants. Omicron's doubling time is 1.2 days, as we see in South Africa strain. So that's something to be concerned. And of course, I may relate to a UK study where they say, though it's a very small, chunk of population that is being enrolled in this study, but most of the people who got infected, I mean, 12 out of 26, they have actually taken 2 doses of vaccine for more than 14 days, and they got this. So yes, this is very important, and we need to, whether we are vaccinated, whether we are not vaccinated, that's the big concern now. And when we talk about, how it differs from a pandemic and endemic, yes, pandemic, when normalized, it's called an endemic. But reality is when there is an equilibrium state is reached. But this equilibrium is not always stable, Hence the seasonal waves of outbreaks that happen. So this brings a question, to all of us, whether we call these waves the epidemic waves or the endemic waves. So we never know. That's the biggest part. And very concerned to me, that one statement that is being came out to you is when it is being transmitted from animal, it's even deadliest. So of course, there is an organization called OIE, which is called One World Health. So recently they have reported around 400 outbreaks of corona among animals, which is in 14 species and 30 states. So this is really concerning, because you never know when corona will also become a zoonotic disease, and it's very difficult to control. So with this, I just try to summarize what are the priority investigations when you say public health risk to Omicron. Transmissibility, you have rightly mentioned, with the increased likelihood of transmission with COVID. Clinical course, increased severity of risk and hospitalization and death. There might be diagnostic failure, because Holland could not able to say that they have Omicron cases unless they go back and retest their already laboratory saved strains and found it is, oh yes, this is Omicron. And then decreased effectiveness of immunity, where we have increased likelihood of reinfections and vaccine breakthrough, and decreased susceptibility of drugs and therapeutics, which is called, as you have explained, the antibody therapy evasion. So yes, these are the few concerns when we are evolving with many mutant strains of COVID. With this, I would open this floor for questions and answers from the participants and from the panel members if there. Thank you so much.
Thank you.
Any questions you may directly ask, or you can put a chat box and I can refer to Dr. Sitesh.
One question someone has sent me, if I could, Priyakant. This person is asking why Moderna and Pfizer are messenger RNA vaccines, and why don't we have that in India? What is the advantage of having mRNA vaccine?
So first, let me tell you that while we were thinking that these are better vaccines than what we have, the very first 2 cases of Omicron that were described in South Africa were 2 people who had received proper, complete Pfizer or Moderna 2-dose regimens and still got infected. So the virus does not look at which company made it, who made it, how well they made it, or any of these things. We as humans decide that, okay, we don't have this here, means this must be better, and we are missing out on something that's really good. As they say, I call it the grass is greener on the other side of the fence theory. When you look at the real world effectiveness of vaccines, I don't think that, a 94 versus a 81 really translates into a huge difference in how the virus behaves, or how the body responds to the virus. And I think ultimately what we all agree is prevention of severe disease, prevention of hospitalization, and prevention of death is the goal which all the vaccines, mRNA, Covaxin, Covishield, Novavax, whichever you take, are clearly showing they can do. Now, for whoever is asking this question, one of the main reasons why the mRNA vaccines didn't make it to India was the storage difficulty. It has to be stored at -70 degrees Celsius, a very impractical thing to do in India to start with. We don't have very many places in the country where a vaccine like that can be stored. And then imagine trying to transport it to the interiors and the places in India where even getting a refrigerator would be a luxury. Forget getting a -70 degree refrigerator. So given that and several other factors, we do not have an mRNA vaccine. But the good news for whoever is asking this question is there is an indigenously developed mRNA vaccine in India, which is going to hopefully get into the marketplace or into the approval zone within the next 2 to 3 months, which will give us the opportunity. And that is why I said, if we try to replicate what the virus is showing us in the community, you get a real infection with the whole virus, and then you get an mRNA vaccine, you get a fabulous response. And we could recreate that by having, for the people who've taken 2 doses of Covaxin, and follow it up with the new mRNA vaccine that we will eventually have, and we may have a very good. And I think that the entire way I look at it as an immunologist is that it's all about combining. We have all gone after the spike protein like crazy. And what did this virus do? It showed us, boom, I can change 32 points on my spike protein, and it will take you months to make your new vaccine. Okay. So I think that it's a wake-up call for all of us that we really, need to keep up our vaccine. Like, imagine if someone told you that there is a 2-year-old flu vaccine or a 1.5-year-old flu vaccine, and there's a new variant of or a new strain of flu that is circulating in your community, and I'll vaccinate you with the old one. Most people would say, sorry, give me the new one that has just come out. But we are still doing this because we don't have options. Now, the people who have the mRNA technology said that they can get a new vaccine within 2 months. This was their big ESP when they came out with the vaccine in the latter part of last year. But it's been over a year and we don't have another upgrade to the vaccine. So while mRNA has its advantages, I think that we are at no short change. We are at no disadvantage here in India. And we have reasonably good, decently working vaccines, which if taken properly, can protect us from severe disease and also from, I would say, mild to moderate disease in many cases.
Thank you, Dr. Sitesh, again for the nice explanations. If there is not any more questions, I have one question. So we talk about a lot with respect to the immunity wall. There are certain country specific, there are certain region specific. But when I see the last data of UK, this COVID-19 sort of, showing the recent data is extensive across all age groups, starting from less than 15 to more than 75. So if you see a immunity wall in UK, it is kind of being, the coronavirus is there in all those groups. So is there any particular reason to that? And if it is there, is it going to be the same situation in other countries and other regions as well?
So I would say that, this is one of the concerns that, we cannot practically do extensive genomic analysis, and there are variants that are going to circulate simultaneously in the community. So Omicron with Delta, with maybe certain parts of the world, Alpha, I know that certainly in South Africa and in UK especially, there's been, transmission of several of these in different regions. Suggesting, and like we knew that Delta was affecting younger people, we knew Delta was affecting children. So far we know that Omicron seems to be affecting people between 20 to 40. So when you have multiple of these different variants circulating, we recognize that this virus is really not looking at boundaries, including an immunity wall or an age boundary. What we know is that kids get a milder disease, they recover faster, they don't easily catch it again because their immune systems are more flexible. As a person gets older, there is something called immune senescence that occurs. And hence there are parts of their immune system that forget things, is the way to, as we get older and we forget things, it's something like that with the immune system. And that's the reason why reinfections are possible. That's the reason why these age barriers are not being followed. So I certainly believe that we will continue to see a spectrum and a range of people getting affected by different variants at different points of time. It's going to be very interesting to see whether some of these variants do better in certain seasons of the years. We don't know at this point of time. This is an unanswered question. But for us to believe that because Omicron is not affecting the older people, they are safe, would be a big flaw, because it may very well prove to us that it can do that if it has the right opportunity with people who have weakened immune systems or waned immune systems. So, but certainly the what I call the density of receptors that are there in different organs, the way the rest of the immune system functions. See, one of the reasons why bats do so well, bats have been coexisting with these coronaviruses forever. There is something called interferon alpha that is constantly turned on in bats, like at a huge level. And interferon alpha is something that helps your immune system, through the innate immune system, knock out anything that comes in front of it. Now we can't do that because too much interferon alpha also gives you diseases. Okay. But recognizing that kids tend to have more of that and a more prompt response with that kind of a change. So they get fever, they get higher fever, they get better faster. Older people don't do that all the time, but Delta forced them to do it, and hence they got sicker. So we have to recognize that with time, therapies will evolve, treatments will evolve. We will understand more about the virus and how to deal with it at the earliest stages. But at the bottom of this all, I would tell is that every age group needs to focus on their own health and immunity through diet, lifestyle, exercise, fresh air, good night's sleep. Means when you do that, regardless of age, you are increasing your chances that whether there is an immunity wall or not, you're protected.
Right. Thank you so much. This is very nice.
Sorry, the same person is asking a question. I don't know why they don't want to identify. He or she is saying that I had both the shots, jabs in India. Now, can I have booster from Pfizer or Moderna actually?
So the answer to that question is nobody can restrict them or stop them. Okay, they can easily fly to the Middle East and get a shot of either of them. I've had a lot of patients who've done that. Okay, that's the nearest place they can get it for a good price, and obviously the cost of traveling and everything involved. Will it help them? As I said, theoretically, yes. I believe that mixing and matching vaccines makes a lot more sense than getting 3 doses of the same vaccine. As an immunologist, it just doesn't make sense unless you have an upgraded vaccine of that you're giving. So if the person really had a reason to get a third dose or get a booster, then yes, taking it from a different vaccine platform would make all the sense in the world. We don't have data on whether, taking a Covaxin after 2 AstraZeneca, Covishield vaccines, we don't know. Maybe that may be just as good. Maybe getting a Covishield vaccine after 2 doses of Covaxin may be just as good. We don't know. There are too many unanswered questions at this point of time, but it would not be inappropriate for the person to think of getting a different shot after 2 doses taken in India of either Covishield or Covaxin, if the need and the appropriateness is there.
Great, thanks.
Thank you, Dr. Sitesh. Is there any more questions?
Tripti Desai ma'am has raised the question, raised the hand, sorry. Let me. Ma'am, can you post your question in Q&A section, please?
It was a wonderful presentation, Sitesh. It was just amazing, actually.
Thank you. Thank you.
My colleague Bhavna Sati just messaged me that we should call him to teach our students, actually.
As times improve and travel becomes better, I'll be happy to do that.
Right.
Sure.
Or we'll do virtually.
Professor, can you please convert Tripti ma'am to as a panelist so that she can ask?
No, sure. I'll do that.
Please.
Or she can just be on chat bot, actually.
I would echo Dr. Anil. I mean, this is something I thought is more of clinical. So what a public health person like me is doing, but you have very well integrated into a public health domain. So this is basically you have given a picture of overall, worldwide picture. Then you compare
Absolutely.
to Indian, and then you have talked about genomic sequencing. You have to talk about the challenges, the genotypes. So it has quite touched on all the components that we talk in public health. So very holistic approach in this presentation.
Exactly.
Thank you very much.
Really appreciate it.
Thank you.
Tripti ma'am, if you are listening us, you'll have to accept the request. We've sent you a panelist request.
Dr. Sudhir Raji, Dr. Manoj Gupta, any questions, any comment?
It was a very, very nice presentation. And for a person outside public health, it was very, very illuminating to hear you, and especially the immunologist's point of view. I thank JSPH, ANILG, and all present here for such a lovely presentation, which enlightened, as one would say, the common man. So thank you very much, sir. All of you from that fraternity. I thank Mr. Roy and of course Anilji and Prasanth. I hope I'm pronouncing it correctly. Priyankaya Nayak sir and Anil Purohit sir, and of course Mr. Jagdish Harsh for being there, and for always. I think we had one episode 9 a few days ago, and we are here with episode 10. So we are constantly learning and moving ahead. Thank you very much, and appreciate that we can together do something and bring about a change. Thank you so much.
Thank you very much.
Thank you.
Manoj, do you want to say something?
Yes, actually, Dr. Sudhi has said everything what I wanted to say, but really it was a great session, sir. Dr. Sitesh, it was wonderful session. I am from engineering background, but I understood every word what you have said. So this kind of presentations are very much, you can say, required for everyone to learn and understand about the disease what is happening right now. So thank you very much, sir. Thank you.
So Priya, I can see a question. I think someone has.
Yes. The question is, I have a patient with comorbid condition in her late 50s. She took first dose of COVID shield in May, and suddenly she developed anxiety towards vaccines as she had some side effects after taking the first dose, and she skipped the second dose. So her question is, can she take the second dose now after 6 months?
The answer is absolutely yes. When it comes to vaccinations, there is something called catch-up vaccination. We do this all the time with children. Kids who are supposed to get a vaccine at 15 months don't show up till they're 3 years old. There are protocols and procedures in children that we follow depending on the age and what the booster is and what the combinations are. But the bottom line is we try to catch up and give them as many doses as we can. So while the degree of boosting that would have been there within a 6, 8, 12-week period would be a little different, it's not that you will not see a boosting, because there are multiple arms of the immune system. The humoral arm, the antibody arm may have declined more, but the T cell memory and the B cell memory would certainly get stimulated with the dose given 6 months later also. And hence, I don't think the person needs to take 2 doses again in the required duration. They should just go ahead and take their second dose, and that's what I would do.
Right.
Thank you, sir.
Thank you.
So I think this was just great, actually. And if anybody's any comments or questions, otherwise, Priyakant, should we close it?
Yes. Thank you, Dr. Sitesh. I mean, though there have been a lot of very, very new raw data for Omicron, but it's still very preliminary. But to summarize, I can say, in terms of transmission or spread, we know how to reduce the mitigation measure, reduce by mitigation measure. First thing first, especially mask, medical grade, distancing, ventilations, air filtration, as you have rightly mentioned. That's important. That's the good news, for Omicron. Bad news is case doubling every 2 to 3 days, 3-fold higher transmission than Delta, household contact. So that need to be careful. In terms of vaccine effectiveness, especially when we talk about mRNA vaccines, it gets to 75% with a booster when you have a vaccine plus strategy. Bad news is it drops to 35% with only 2 doses, and booster got to 95% with Delta. So it is even bad than Delta. And if you talk about illness, severity, and virulence, markedly less hospitalization than prior variants. So cases are mostly mild here. But bad news is a lot more cases as compared to Delta or Alpha, and the doubling time is high. Immune escape, I mean, you are the master. It's blunted by third shot. But here, the bad news is reduced vaccine effectiveness. And as you have mentioned, monoclonal antibodies are less effective. So these are the key driver of rapid spread. And coming to reinfection, prior COVID plus vaccination actually provides solid protection. That's the good news. But the bad news again, at least 2 to 2.5% increased compared to the prior variants, as we see in the UK data. So overall, I would always summarize saying that 3 things, prevent, treat, and test. That goes like any sort of epidemic or pandemic. And then the basic measures like mask, distancing, ventilation, air filtrations. So these, and of course, you have already mentioned lifestyle, lifestyle modifications, keeping yourself healthy. That are key. Otherwise, you keep on getting more number of mutants over the period of time. But how effectively we can actually, prevent that, that's more important. So thank you. This has been an excellent presentation and excellent panel. The questions are being great. And it's really great learning experience to this webinar. Thank you so much.
Thank you very much
Thank
to Dr. Anil, to the JSPH, the entire team here, to Dr. Priyakanta, and everyone else who's here for the kind words. It's a pleasure being here with all of you all, and I hope that everyone stays safe, stays protected, and has a healthy time going ahead into the new year. And let's just pray for the best, that we finally see all the lights at the end of the tunnel and reach there as soon as possible, so we can get back to our lives with all the precautions that we need to continue taking. So thank you very much and stay blessed.
Thanks.
Dr.
Thank you.
Sitesh, I'll just request you to be there for just 5 more seconds, and we'll just capture the picture. The ritual will just capture a picture to make it memorable. And I'll just request everyone to just turn on the camera then. We'll just have a click. Sudhi ma'am is here. 3, 2, 1. Saji's. Thank you very much, Dr. Sitesh. Thanks a lot. Thank you, everyone.
Thank you.
Good night.
Good night.
Right.
Good day.
Good night.